A very quick introduction, Atul, for anyone who's just joined, who wasn't on the first talk. So again, it's a real pleasure to introduce Dr. Atul Mehta, who is the chair of the pulmonary pillar of the Fellows Track Symposium. He is a distinguished internationally recognized pulmonary clinician and researcher, and quite active in the areas of lung transplantation and interventional pulmonology, among many areas. He has an endowed chair at the Cleveland Clinic, where he has been for many years, and he's been named a giant in pulmonary medicine by the American College of Chest Physicians and received the Distinguished Clinician Award from the American Thoracic Society. So with that background, I will turn this session over to Dr. Mehta.
Thank you very much, Deb. You know that over the years, I'm just following your footsteps. That's what I'm trying to do. Thank you very much for the kind remarks. So in next 45 minutes or so, what I'm going to do is talk to our fellows regarding metaphorical signs in computed tomography of the chest. I have no conflict of interest related to my talk. You know, let me start my talk by asking the fellows, first question is, what is the medical crime of the century? Have we committed a crime? And being an old pulmonologist, I would say over the years, we have murdered the chest x-ray. Nobody pays that much attention to the chest x-rays anymore, including the radiologists. And that made me write this editorial several years ago. I was making rounds on the pulmonary service, and I asked one of the interns to read a chest x-ray for me. And she gave me such a dirty look, I still remember that, because she had never seen a chest x-ray in her 6 months of intramedicine residency. So that made me write this particular editorial, and even though I continue to teach chest x-ray, I think I'm fighting a losing battle, as we are looking at more and more CT scans and we are ordering more and more CAT scans, and hence it is important to know all the signs seen on the CT scan of the chest. Even though hanging on to my chest x-ray interest, you know, what I say is, when you look at the chest x-ray, one view is no view. And as I'm showing you here on this particular slide, on a lateral view, you can see there is an endobronchial lesion which was missed on the findings. You know, on the report, it said it's a normal chest x-ray. You got to look at lateral view as well. I complained to the radiologist that this resident had not seen any chest x-rays for 6 months, and he said he does not look at the chest x-ray either because it is of poor sensitivity. And I was wondering in my own mind whose sensitivity the radiologist was talking about. Nevertheless, as I mentioned to you, we are doing more and more CAT scans of the chest, and now, in my opinion, normal HRCT is an oxymoron. There is nothing like a normal HRCT. Our radiologists can look at, or they can identify the nodules, which is 2 millimeters in size. For the fellows, do you know what is the most common indication for the CT scan these days at the Cleveland Clinic? Even our radiologists know what is the most common indication. It is called as IMSS. And what does that mean? It means it may show something, and that's the reason we do CT scan of the chest these days. I encountered a patient who had 3 CT angios in 1 week. He was an 18-year-old kid who had pleurisy, and he went to the emergency room to renew his narcotic prescription, and every time he went to the emergency room, they repeated a CT angio on him to rule out pulmonary embolism. I had seen a patient who had 13 CAT scans done in 3 months period, and I also looked at a chart. There was an order which said CT scan of the chest every Monday. Our chest surgeons do CT scans to look at the chest tube position these days because we cannot identify that on the CT, on the chest X-ray of the patient. In my opinion, chest X-ray, reading chest X-ray is a lost art, and we are losing analytical approach to the interpretation of the radiographs. I also refer to this as digital watch syndrome. You know what digital watch syndrome is? If all the watches in the world become digital, we will not know what is the short arm and what is the long arm on our wristwatches, and that is a digital watch syndrome. Nevertheless, what I'm trying to make a point that we are doing more and more CAT scans of the chest, and hence we should know all the signs I'm going to talk about. Another fact is CT scan begets CT scan. One CT scan leads to the next CT scan. We do CT angio as shown in this particular slide on the top level here, and it shows some ground glass abnormalities. Whether this is real or not, to rule out interstitial lung disease, we do another CT scan without contrast to prove that patient has got a normal lungs. CT scan, questionable fluid, then we do a CT scan in prone position to rule out congestive heart failure. If there is a CT scan with mosaicism, then we order an expiration CT scan to confirm that particular finding. You do abdominal CT and you find an abnormality on the abdominal CT involving the lung, so then you order a full CT scan of the chest. Very often what we do at the Cleveland Clinic, a patient comes in with a nodule on the CT scan of the chest, then we ordered another CT scan of the chest for the EMN or electromagnetic navigation protocol so that we can do a fancy advanced bronchoscopy on these particular patients. If you suspect tracheobronchomalacia or you suspect excessive dynamic airway collapse, then we order dynamic CT after doing a regular CT. And all of you are aware of doing screening for the CT scan, screening CT for the lung cancer. And if you find some abnormality, you're going to continue those patients with follow-up CT scans. While talking about the screening for lung cancer, I'm sure all of you are aware that that has been approved in year 2015. And we are doing large number of low-dose CT scans looking for the lung nodules, in other words, screening for lung cancer. And what it is going to do is by December 2020, this year, we are projecting that maybe there will be more. There will be 10.7 million more CT scans performed in this country because of the CT scan, because of the lung cancer screening program, which will diagnose over 75,000 more lung cancers. I also want to point out here that when you perform a low-dose CT scan of the chest, in approximately 7.5% of the patients, you are going to find some other abnormalities other than lung cancer. I'm not going to go in the details of the indication where you are going to do lung cancer screening CT. Having had said that, I just want to show you that how much radiation exposure we expose our patients to in relation to all the radiographic studies we order. If you just order a simple CT scan of the chest, the exposure, radiation exposure to the patient is 0.1 millisievert as it is shown here. You do low-dose CT of the chest, it is 20 times more. If you do the regular CT, it is 70 times more. If you do CT angio, it is 160 times more. If you do cone beam CT, with low dose, it's about 46 times more, and you do regular cone beam CT, the exposure is 237 times more. I'm always worried that if radiation would cause lung cancer, then how we are going to follow those patients. That's just a question which boggles my mind. Anyway, I have already made that we are doing lots of CT scans of the chest, and hence skills at interpreting the findings are extremely important. Therefore, you need metaphoric CT signs in chest imaging. They are important to recognize several unique findings that gives you diagnosis. Obviously, that would shorten the list of differential diagnosis. And when you combine the clinical data with the CT findings, you further narrow the differential diagnosis. Some of these signs, as I mentioned to you, could be pathognomonic, and these signs also improve the uniformity in reporting the X-ray findings. There are different types of metaphoric signs, that is parenchymal, airway, vascular, and some of them are pleural based. I'm just showing you this sign on the left of the slide that is a crop formation. You know, if you see something like this from the sky, you may think that aliens exist. But we know, I just want to point out that not all the signs you see are that sensitive or specific. So you have to have differential diagnosis in your mind as well. Before you start looking at the CT scan or trying to interpret the findings on the CT scan of the chest, one must understand the anatomy of the lobule of the lung. And on the left side of the slide, you can see a nice depiction of artist's rendition of the secondary lobule of the lung. It is the fundamental unit at the subsegmental level. It is polyhedral in shape. The largest diameter is about 1 to 1.2 centimeter. It carries about 12 acini as it is shown right here. And this acini have the centrilobular structure, that is this portion of the acini. This is central lobular structure. There is terminal bronchioles, there is pulmonary arterioles, and there are central lymphatics. If there is an abnormality within the lobule of the lung, then you know that the pathology exists in the terminal bronchioles, pulmonary arterioles, or central lymphatics as it is shown right here. On the other hand, if radiograph is showing you the abnormality in the interlobular septum, which is made up of either the pulmonary veins or lymph channels, that is where the pathology is. In other words, that if this interlobular septum is thickened, it could be pulmonary veno-occlusive disease, or it could be just engorged lymphatic as a result of congestive heart failure, which makes the curly V lines. And just to show you and compare this artist's rendition with the real CT scan and showing you the autopsy specimen as well. This is the secondary lobule. This is the centrilobular structure, and this is interlobular septum, as it is shown here. All these, this is the interlobular septum right here. That's what the abnormality is. And you see these are all centrilobular nodules, which is shown right here. And an autopsy specimen, as you see, this is the secondary lobule of the lung right here, and this is the interlobular septum thickening. That is what I'm trying to highlight on this particular slide. This is the lung parenchyma. This is the lobule itself, centrilobular structure, as I'm pointing out here, and the interlobular septum. With that information in mind, I want to show you the first sign, and that is air crescent sign. As you see the crescent moon right here, and exactly the similar picture you are seeing within the lung field right here. This is the crescent sign. It is crescentic or circumferential rim of radiolucent airspace within the parenchymal consolidation or a nodular opacity, as it is shown right here. When you see this, the most likely diagnosis, crescent sign, the most likely diagnosis is invasive aspergillosis. However, some cases of tuberculosis, hydatid cyst, lung abscess, bronchogenic carcinoma, and pneumocystis carinii pneumonia has also occasionally shown crescent sign. Once again, as I mentioned to you, unless proven otherwise, it is going to be invasive aspergillosis, and the pathology behind that is a fungal hyphae that is leading into the vascular invasion, which leads to thrombosis, which leads to infarction and eventual necrosis. The crescent formation, this air around this particular lesion, is the separation of the devitalized necrotic center from the surrounding opaque rim of hemorrhagic tissue. And believe it or not, it is as a result of recovery phase of the disease. So if your immunocompromised patient is showing you crescent sign in suspected invasive aspergillosis, that has got favorable prognosis, 67% versus 8% in absence of the crescent sign in patients with invasive aspergillosis. When we are talking about crescent sign, we should also talk about monod sign, and this is a perfect example of the monod sign. As you can see here, there is a cavity, and then there is something sitting inside the cavity. There is a fungus ball. So what is the Monod sign? Air surrounding a fungus ball in a pre-existing pulmonary cavity, which falls to a gravity-dependent location, as it is shown right here. It is actually a mass within a pre-existing cavity. And this is not a Crescent sign. The differential diagnosis that it is mainly a fungus ball, and most likely it is aspergilloma, but it is happening within the pre-existing lung cavity. So let me show you what is the difference between the Crescent sign and the Monod sign. The most important thing is when you see the air Crescent sign, the individual is usually immunocompromised, while when you see the Monod sign, happens usually in an immunocompetent patient. This patient has got no patient is not immunocompromised. The cavity could be sarcoid cavity, tuberculosis cavity, or it could be COPD bleb, where fungus ball would occur. The mass is within the cavity. Most likely it is aspergilloma, and it gravitates to the depending areas of the cavity. That is the Monod sign, while this is the Crescent sign. And I think I've given you enough differential between these two particular signs. One other point I would like to make is not all fungus balls are aspergillomas. When you suspect aspergilloma, when you suspect fungus ball, besides aspergilloma, it could be also from coccidiomycosis, it could be actinomycosis, as I'm showing you here in this particular patient. Nocardiosis, candidiasis can all cause picture of fungus ball, which could be confused with aspergilloma. Occasionally, intracavitary hematoma, tuberculosis, adenocarcinoma, pseudo-Escherichia boydii infection, hydatid cysts in a larval stage can also show you picture that of Monod sign, and that is what you want to remember. The next sign I would like to talk to you about is a halo sign. Once again, the halo sign is a solid pulmonary nodule surrounded by circumferential ground glass opacity, as it is shown in this particular slide. Solid mass surrounded by the halo of ground glass opacity. This is halo sign. And once again, unless proven otherwise, this is invasive pulmonary aspergillosis. However, other conditions such as mucormycosis, adenocarcinoma in situ, granulomatosis with polyangiitis, amyloidosis, sarcoidosis, and occasionally metastatic cancer can also produce this type of picture. Once again, I'm showing you another example of the halo sign of invasive aspergillosis. The central nodule is usually infarction, and the surrounding ground glass abnormality or halo is hemorrhage around this particular lesion. Again, as I mentioned, the incidence is very high with invasive pulmonary aspergillosis, and over the time it may disappear. This is a beautiful autopsy example of invasive aspergillosis and halo sign. As you see it, this is the infarcted area and surrounding hemorrhage, which is causing the picture of halo sign in this particular patient. When you talk about the halo sign, the next sign you should know about is Atoll sign, or it is also referred as reverse halo sign. As you can see here, there is peripheral dense area. There's a coral reef in Maldives. There is a lagoon in the center. This is a softer area, and there is a dense area around this particular soft area. The central ground glass opacity, which is surrounded by crescentic or circumferential dense airspace consolidation. And this is a beautiful example of Atoll sign or reverse halo sign. The solid area is at the periphery of the ground glass abnormality. And this particular sign, Atoll sign, was first described in patients with COP or cryptogenic organizing pneumonia, which was referred as BOOP in the past. Nowadays, there are some other conditions such as MTB, community-acquired pneumonia, pneumocystis jirovecii pneumonia, lymphomatoid granulomatosis, GPA, lipoid pneumonia, sarcoidosis, certain neoplasms such as bronchoalveolar cell carcinoma, and paracoccidiomycosis all have shown signs of Atoll sign in some patients. Once again, another beautiful example of Atoll sign. The central ground glass abnormality or opacity is a result of alveolar septal inflammation and cellular debris, while the peripheral consolidation is organizing pneumonia within the alveolar duct, and that produces Atoll sign on the CT scan of the chest. Let's briefly touch upon Cheerios sign. By the way, I'm not making up these terms myself. These are all medically accepted terms by radiology societies, including Fleischner Society. Cheerios sign, the synonym is also open bronchus sign, which is proliferation of neoplastic or non-neoplastic cells around the patent airway. Patent airway surrounded by either neoplastic or non-neoplastic cells proliferation, and that is Cheerios sign. I'm sure all of you know that this is the breakfast cereal made by General Mills, and you can almost feel that the Cheerios are falling into the CT scan of the chest, unless proven otherwise. In a smoker, it is going to be pulmonary Langerhans cell histiocytosis. Metastatic adenocarcinoma or occasionally primary adenocarcinoma can also present in this particular fashion. With a proper clinical setting, you can think about fungal infection, lung metastasis, rheumatoid nodules, and once again, granulomatosis with polyangiitis. Once again, trying to show you the artist's rendition of Cheerios sign, proliferation of neoplastic or non-neoplastic cells around the open bronchus, as it is shown right here. And this is the Cheerios sign in a patient with Langerhans cell histiocytosis. Similarly, again, once again, I'm showing you the Cheerios sign on the CT scan of the chest, young male smoker, and this was as a result of pulmonary Langerhans cell histiocytosis. Let's talk about Comet tail sign or Talon sign. How it is described, I'm sure all of you are aware of the picture of the comet here, but it's a curvy linear opacity that originates from the pleural base opacity going towards ipsilateral hilum. Okay, so this is curvy linear. This is the curvy linear opacity that is originating from the pleural based opacity going towards the hilum. This is the comet tail. This is the comet tail, as it's shown right here. And this is the curvy linear opacity attached to the pleura. And this comet tail is made up of blood vessels and adjoining airways. And unless proven otherwise, in most cases, this is going to be a benign condition of rounded atelectasis. This does not need to be worked up. This just needs to be followed if you have any suspicion or any risk factors for bronchogenic carcinoma. But again, it is only a benign condition. When it gets even worse, that is also occasionally referred as Talon sign, as you see, claw of a bird of prey, as you see here, Talon. And this is a beautiful example of the Talon sign, okay, which comprises of the vessels and adjoining airways that get pulled together in a mass as the lung collapses around this. And usually these patients have pleural effusion before, and when that pleural effusion subsides, it leaves this kind of mass lesion. Bronchovascular bundle entering the mass from all sides. Pleural thickening is always present when you have this Talon sign. As I mentioned to you, 99% of them are going to be benign. Over the period of time, they may reduce in size and may even disappear. This particular sign, corona radiata sign, it goes without saying, as you can see here, how the corona radiata looks like right here. And this is the corona radiata sign in a patient with lung cancer. And basically, you see all these spikes, just similar to the coronavirus spikes, which are the spike proteins in coronavirus. But these are the lymphatics. These are the lymphatics which are involved in a patient with bronchogenic carcinoma, which gives rise to this corona-like appearance on the CT scan of the chest. It is also, if it's a large lesion, it is also referred as sunburst sign. It is a solitary pulmonary nodule or a mass with spiculated margin with distortion of the surrounding blood vessel. And when you have corona radiata sign present, it gives the odds ratio of this lesion to be bronchogenic carcinoma by 2.5-fold. And this is just an example of a sunburst sign when that lesion gets very large. And it looks like, there's, once again, there is corona radiata around it. This is a sunburst sign, and this is all lymphatic involvement with bronchogenic carcinoma, and this is lung malignancy. Very interesting sign, galaxy sign, or sarcoid galaxy, as it is shown here. Coalescent granulomas appearing as a central dense mass with a tiny peripheral satellite nodules akin to a galaxy cluster, as it is shown here and as it is shown here. Unless proven otherwise, this is sarcoidosis. Very rarely on progressive massive fibrosis, of course, you have a good history in this particular situation, or active pulmonary tuberculosis may produce galaxy sign. However, in proper clinical setting, this is sarcoidosis. If there is mediastinal lymphadenopathy and calcification, that could further aid in making the diagnosis of sarcoid galaxy. Another interesting sign, I'm sure all of you have seen it, enjoyed it, and that is crazy paving. And this is a beautiful example of crazy paving on the CT scan of the chest. This is actually the description or the depiction of crazy paving. And radiographically, it is the thickened intralobular septa on the background of diffuse ground glass opacity. As you see, there is a diffuse ground glass opacity, and there is thickening of the interlobular septum. The GGOs represent concomitant alveolar process, and this sign was initially described, first time it was described in patients with pulmonary alveolar proteinosis, and now there are a variety of conditions, including sarcoidosis, have also been shown to represent or to show crazy paving. Where does the name crazy paving come from? I'm sure many of you have been to Barcelona and have visited Gaudi's Park in Barcelona. He was a crazy architect and he never believed in the straight line. So this is how he made the crazy paving. And when the CT scans represent or look like this crazy paving, that is what the finding we are describing. This is not crazy paving, even though one Argentinian article wrote about it. This is actually cobblestoning and not exactly crazy paving. There are several differential diagnoses for crazy paving these days. Pneumocystis carinii pneumonia, old-fashioned bronchoalveolar cell carcinoma. I already mentioned to you alveolar proteinosis and sarcoidosis, occasionally NSIP, COP or organizing pneumonia, lipoid pneumonia, and even ARDS in critical care setting can show crazy paving. Pulmonary hemorrhage syndromes have also been associated with this particular finding. Just to show you some examples of crazy paving in patients with pneumocystis jirovecii pneumonia. This is the patient who had old-fashioned bronchoalveolar cell carcinoma or invasive adenocarcinoma, according to the new differential diagnosis or new nomenclature, alveolar hemorrhage, ARDS, and variety of chemotherapeutic agents, including methotrexate and topotecan, bleomycin, and amiodarone can also cause crazy paving on the CT scan of the chest. This is the case taken from Journal of Bronchology, and as you can see here, patient has got a beautiful crazy paving in the superior segments of both lower lobes. And actually, this patient had lipoid pneumonia. The diagnosis was established just simply by BAL, the bronchoalveolar lavage fluid, showing that the fatty emulsion was floating over the bronchoalveolar lavage fluid, and this was indeed a lipoid pneumonia in a patient who was using some nasal drops with lipoid preparation. And an aggressive bronchoscopist also performed a cryobiopsy on this thing, showing that there is lipoid pneumonia in this particular situation. Another very interesting finding on the CAT scan she ordered, it is referred as mosaic attenuation. What is mosaic attenuation? It is variable attenuation seen on a chest CT in a lobular or multilobular distribution. Lobular or multilobular distribution, as you see here, variable attenuation. This may be normal, or this may be normal, or this is normal and this is abnormal. That is a possibility. Interestingly, this mosaicism could be seen in 3 different types of pathologies. It could be as a result of small airway disease, it could be as a result of infiltrative lung disease, or it could be as a result of vascular lung diseases. When this mosaicism is seen in small airway disease, usually it is air trapping as a result of bronchiolitis obliterans. And I frequently see these things in patients with chronic rejection in my lung transplant population. It could be as a result of infiltrative disease such as hypersensitivity pneumonitis. And it was initially indeed described in patients with hypersensitivity pneumonitis, but occasionally eosinophilic pneumonia, cryptogenic organizing pneumonia, and PJP can also show mosaicism, and because of the infiltrative disease, and I'll show you the better example of this. Patients with chronic thromboembolic disease, pulmonary hypertension may have mosaicism, not as a result of infiltrative process or airway obstruction, but it is mainly as a result of oligemia or lack of perfusion in the area of pulmonary embolism. I do not have time to take you through this algorithm to come to the differential diagnosis when you see the mosaicism, but the point I would like to show you here, this is infiltrative type of mosaicism. As you see, there are areas, hyperlucence, a hypodense area, and hyperdense areas, as you see the ground glass abnormality here. And this patient actually had PJP pneumonia, while this particular patient, the pulmonary artery is almost missing as you see it. And this area of mosaicism, as you see, hypoperfused area, is really as a result of hypoperfusion from chronic thromboembolic disease, but this is also a mosaicism on a CT scan of the chest. So you have to have clinical information to interpret mosaicism in your patients. I really saw this thing very recently in one of my patients, and this is referred as head cheese sign. I'm a vegetarian, so I don't know what the head cheese was, but this is an example of the head cheese, which is a type of French food that is made up from the pieces of meat obtained from various parts of different animals like calf and pig and so on and so forth. So this is how the head cheese is supposed to look like, but this is the example of head cheese sign on a CT scan of the chest. And most likely it is a result of subacute hypersensitivity pneumonitis. The most likely diagnosis is subacute hypersensitivity pneumonitis. It is juxtaposition of distinct radiographic areas of low, normal, and high attenuation, and that makes the head cheese sign. Mycoplasmal infection, sarcoidosis, and respiratory bronchiolitis may also present with head cheese sign. I spent some time in Abu Dhabi in Middle East in UAE, and I used to see dust storms very often. And this is an example of a dust storm or sandstorm, and it is also referred as a sandstorm sign, black pleural line sign. As you see this line, black line underneath the dust storm, similarly, you can see this thing on the CT scan of the chest, black pleural line sign or a sandstorm sign. Lots of dense particles right here, almost like a dust particle or a sand particle or a calcium particle. And again, it is seen in patients with pulmonary alveolar microlithiasis. This is the diagnosis in this particular patient. It's a black lucent line between the ribs and the surrounding calcified parenchyma, as I'm showing you right here. It is diffuse, there is diffusely dense pulmonary micronodular calcification. And again, as I mentioned to you, the diagnosis is pulmonary alveolar microlithiasis. Very rarely metastatic thyroid cancer can do this thing. And again, I'm showing you other examples of sandstorm sign or black pleural line sign. Diagnosis is pulmonary alveolar microlithiasis. Beauty lies in the eyes of the beholder. Some people call it a water lily sign, or some people call it Camelot sign. Now, I'm sure all of you recognize here, you see that there is a cyst here in the lung, and something is floating in this particular cavity here, which looks like water lily. This is water lily sign, and some people refer to it as a Camelot sign as well. And this is hydatid cyst. Hydatid cyst in a lung with a free floating endocyst. This is exocyst. This line is exocyst, while the endocyst has ruptured and fallen into this particular cavity, and it is floating on the pre-existing fluid. So that is what makes a water lily sign. hydrated cyst in the lung with a free-floating endocyst which collapses and floats in the cystic fluid like a water lily or a camelot. It's also referred as sunrise or sunset sign, and it is pathognomonic for echinococcosis or hydrated cyst of the lung. Diagnosis is made by positive serology in these patients. These are some other examples, that is mass within the cavity, serpent sign, meniscus sign, oval mass, Kumbo sign, water lily sign are all examples of echinococcus cyst. This is another example of water lily sign or camelot sign. And this is an endoscopic picture of a patient with endobronchial echinococcosis, just to show it to you. These were all parenchymal signs I talked to you about. In the next few minutes, I'll talk to you about air bronchogram signs or airway signs. And again, what is air bronchogram sign? Nothing, it's very simple. Here, the air is behaving like a contrast material, and that is air bronchogram sign. It just tells you that patent airways surrounded by opacified lung, air is behaving like a contrast, and it points out to you that airway obstruction is unlikely, and most likely diagnosis in this situation is community-acquired pneumonia. If it is symmetrical, bilateral, it could be pulmonary edema, again, severe interstitial lung disease, occasionally pulmonary infarction, bronchoalveolar cell carcinoma, or adenocarcinoma of the lung, and non-obstructive atelectasis can also produce air bronchogram sign. All pulmonary fellows interested in interventional pulmonology must know what is a positive bronchus sign. When the airway is leading directly to a peripheral lung nodule or a mass, that is called as positive bronchus sign. So as you see this in artist's rendition, the bronchus is directly leading to the mass lesion. The bronchus is directly leading to the mass lesion. The bronchus is directly leading to the mass lesion. That is type 1 Suboy classification nodule, positive bronchus sign. The point here is if you do a conventional bronchoscopy, transbronchial biopsy, endobronchial biopsy, brushing, and even conventional transbronchial needle aspiration, your yield would be as much as 90%. When the bronchus is running through the lesion, it's a type 2 lesion. When the bronchus is bypassing the lesion, it's a type 3 lesion. And when the bronchus is obstructed by the tumor tissue or the lymph node, it is referred as type 4 Suboy classification lesions. But all of you should recognize the bronchus sign. That would improve the diagnostic yield of your bronchoscopy. Signet ring sign. This is a signet ring, and this is a signet ring sign right here. All of you know that this is bronchiectasis. Here, the bronchus is more than 1.5 times larger in diameter as compared to the surrounding or accompanying blood vessel. Dilated airway is predominantly larger than its accompanying pulmonary artery in the cross-section view, and this is the signet ring sign. The ratio is more than 1. Parallel non-tapering airway seen extending to the lung periphery, which I'll show you the example, and associated findings are, this is bronchial wall thickening, this is bronchial wall thickening, peribronchial cuffing, that is what it is also referred as, and it is seen in patients with cylindrical or traction bronchiectasis. Once again, this is the signet ring, and I'm showing you a beautiful example of signet ring sign in a patient with bronchiectasis. Usually cystic fibrosis patients will have this type of problem or this type of finding. Also patients with common variable immune deficiency who have got recurrent infection or cartilaginous syndrome will show this type of findings. This companion findings or companion sign with the signet ring sign is tram tracking, and this is a beautiful example of tram tracking. Instead of tapering as they go towards periphery, these airways are running parallel with peribronchial cuffing, and once again it proves that the patient has got bronchiectasis. Mainly cystic fibrosis patients, especially if it is proximal. If it is peripheral and patient has got fibrosis, that is traction bronchiectasis, which is also referred as dry bronchiectasis or bronchiectasis sicca, which is also seen following healed tuberculosis, which also produces bronchiectasis sicca. A proximal bronchiectasis could also be seen in patients with allergic bronchopulmonary aspergillosis and in cartilaginous syndrome patients. So this is an example of tram tracking. Very interesting sign, all the fellows should know about this thing, is tree in bud sign. As you see it right here on the top portion of this particular slide, this is tree in bud, multiple centrilobular nodules arranged in linear branching pattern as budding of the tree or budding tree in spring months. This is a beautiful example of tree in bud right here, as you see it right here. This is also a beautiful example of tree in bud sign. What does that mean? It's mainly bronchiolar. This is endobronchial inflammation or bronchiolar infection or inflammation, which is within 1 centimeter of pleura, and it's about 2 to 4 millimeter in size. And first time it was described in patients with MAI, but patients with M. tuberculosis can also show this particular signs. Occasionally in atypical pneumonia, viral bronchiolitis, in patients with aspiration pneumonia, you can see tree in bud sign. Let me show you something different than tree in bud sign, which could be confused as tree in bud sign, and that is finger in glove sign. As you see it right here, this is large airways involvement right here. There is mucus plugging in the airways. This is finger glove sign or finger in glove sign. This is an example of tree in bud. This is finger in glove sign, which is a tubular or branching opacities involving the large airways that resembles fingers. So this is finger in glove. This is finger in glove sign. It's a sign of large dilated airways with mucoid impaction, bronchosyl or mucosyl. They radiate from the hilum, as I'm showing you here very clearly, towards the periphery. It is of low attenuation and they never enhance with contrast material, obviously. Atypical appearances such as ovoid opacities are also common. I'll show you the example of this. While this is tree in bud, that is what I wanted to highlight, which is impacted small bronchioles and non-dilated airways. Finger in glove sign is better seen on the CAT scan rather than on the chest x-ray, but this is, as you can see here, this is also finger in glove sign on the chest x-rays. This was first described in patients with allergic bronchopulmonary aspergillosis, but now we are seeing it more and more with the CT scans in other conditions as well. Once again, bronchiectasis, it may be present in those situations where there is proximal bronchiectasis, there is low attenuation mucus ispissated in the bronchi, and there is clear connection with the central airways. As I mentioned to you earlier, they could be of other abnormal shape, and you see this is an elliptical form of finger in glove sign, and this is in patients with segmental bronchial atresia, and this is just a radiographic diagnosis in a proper clinical setting. This patient does not need any biopsy, or this patient does not need any surgical procedure to confirm this diagnosis. As you can see here, it is very nicely surrounded by hyperlucent areas, and this is segmental bronchial atresia. There are other differential diagnoses of finger in glove sign. We have discussed most of this, and I'll not go in the details of that. As long as you're aware that this is finger in glove sign, that would help you significantly in making the differential diagnosis. Now we are switching the gears from the airway signs. We are going to the vessel signs. Similar to positive bronchus sign, there is something called as feeding vessel sign. As you can see here, the vessel is feeding this particular infiltrate. The vessel is going into this particular infiltrate. And all of you have seen this condition, and this is septic emboli unless proven otherwise. Occasionally pulmonary infarction, metastases, and pulmonary AV malformation can also show feeding vessel sign. One other interesting sign on the CT scan of the chest, which is referred as egg and banana sign on the CT scan of the chest. This is the banana, that is the aortic arch, and this is the egg. This is the pulmonary artery, and when the pulmonary artery is reaching the level of the aortic arch, this is the diagnosis of pulmonary hypertension, and this is what is described as egg and banana sign. As you can see, in a normal individual, pulmonary artery is a significantly lower level, and there is an AP window here. But when the AP window is completely obliterated by this particular density, that is the top of the pulmonary artery, that makes the telltale diagnosis of pulmonary hypertension. Polo mint sign. Once again, this all terminology has been accepted by the societies of radiology, and I'm showing you here. This is the polo mint sign. I'm sure all of you have seen the polo mint, which is partial filling defect in the blood vessel surrounded by a rim of contrast material on a CT angiogram images acquired perpendicular to the long axis of the vessel. This is polo mint sign. There's a huge clot in the same patient. You see this thing here in the pulmonary artery here. This is the polo mint sign. This is the polo mint sign. And this is pulmonary embolism. Occasionally, portal vein thrombosis can also produce picture like this. Very rarely, you can also see a Rigler notch sign. As you see here, this is a mass lesion, and this blood vessels on a contrast CT is producing a notch over this mass lesion. And once again, that proves that this is bronchogenic carcinoma unless proven otherwise. So that is what the significance of Rigler notch sign. The last group of signs are the pleural signs. And here, you see this thing here. This is the visceral pleura. This is the parietal pleura. When both these pleural surfaces are separated by the pleural fluid, and in this particular fashion, in this particular picture, I'm also giving you gas formation in this pleural fluid. This is empyema unless proven otherwise. A beautiful example of visceral pleura, parietal pleura, and this is separated by this fluid with the gas bubbles inside, and this is empyema unless proven otherwise. Split pleura sign, contrast enhancement of the parietal and the visceral pleura separated by the exudative effusion, and that is split pleura sign. It is because of the fibrin deposition along the opposing pleural surfaces and ingrowth of blood vessels. And again, as I mentioned to you in the board examination, this is empyema unless proven otherwise. Occasionally malignant effusion, post-tal pleurodesis, mesothelioma, or hemothorax may look like this. Very quickly, I'm going to take you through some other findings on the CT scan of the chest, which is not considered as signs, but they are just considered as patterns. So let's look at some of the patterns on the CT scan of the chest. Everybody knows this, cannonballs. When you see the cannonballs, it is metastatic carcinomas from an occult primary site or a known primary site, usually renal cell carcinomas, choriocarcinoma, endometrial carcinoma, prostate carcinoma, and even colon cancer can produce cannonball type of pattern on the CT scan of the chest. Miliary pattern, I'm sure some of you have seen this thing. It is diffusely distributed sub-centimeter pulmonary nodules of varying sizes between 1 to 4 millimeter. This is miliary pattern. This is miliary pattern on an autopsy specimen, and this is miliary pattern on the CT scan of the chest. And unless proven otherwise, it is either tuberculosis in a proper clinical setting or geographical area, histoplasmosis, occasionally sarcoidosis, and pneumoconiosis can also present with miliary pattern. Rarely adenocarcinomas, pulmonary hemosiderosis, hematogenous mets from thyroid, renal, and trophoblastic cancer can produce miliary pattern. I'm sure all of you know what honeycomb is, and you know what honeycomb in the CT scan of the chest. And this is idiopathic pulmonary fibrosis or usual interstitial pneumonitis unless proven otherwise. Honeycomb lung is clustered cystic air spaces typically of comparable diameters in order to 3 to 10 millimeters. Occasionally, they could be as large as 2.5 centimeters, subpleural, and characterized by well-defined walls. They are characterized by well-defined walls, and this is honeycombing. This is usual interstitial pneumonitis. Rarely NSIP, DIP, and acute interstitial pneumonia can produce this thing as well. Last but not the least is Swiss cheese sign, as you see it on the lung on the right. It almost looks like a Swiss cheese with big holes inside, and most likely that occurs in patients who have got a blunt trauma to the chest. Recently, we had a patient with a bullet wound injury to the lung, and he presented with Swiss cheese sign on the site of the injury. Multiple pneumatocells with air fluid levels called as hematoneumatocells. And this is what the sign of Swiss cheese sign or Swiss cheese pattern. Saber sheath trachea. That is also one of the patterns you will see on the CT scan of the chest. More than 30% of the patients with saber sheath trachea have COPD. So this is a beautiful example of this. This is a saber. This is a saber sheath. And as you can see here, this is a saber sheath trachea where the AP diameter is 3 times more than transverse diameter. Lengthening of the trachea and its anteroposterior dimension in a coronal plane in absence of mediastinal pathology, limited to the intrathoracic portion of the trachea, and it is seen in 30% of the patients with saber sheath trachea, they either have COPD or chronic bronchitis, as it is shown here. This is probably the last slide. I started with the murder of the chest X-ray, and I'm just showing you the phantom infiltrates. If you see the infiltrate on the left side one day, on the right side the next day, this is also seen in several patients with a CT scan of the chest. When these are fleeting, infiltrate is often referred as phantom infiltrates as well. And these phantom infiltrates could be seen in patients with pulmonary coccidiomycosis. So when you see the CT scan, one day the infiltrates on the one side, the chest X-ray shows the infiltrates on the other side, think about coccidiomycosis, and with a good travel history, you might be able to make the diagnosis. So in summary, reading of the chest X-ray is a lost art. Physicians' reliance on the CT scan of the chest has increased exponentially. Screening for lung cancer will further increase the number of CT scans performed in our country. 7.5% of screening CT shows abnormalities other than lung cancer. Metaphorical CT signs are of vital importance not only to diagnose but also to exclude other diseases. With appropriate clinical and laboratory correlations, many of these signs can be pathognomonic for a particular disease entity. Pattern recognition approach can definitely help in narrowing the differential diagnosis and adds to the uniformity in reporting. I thank you very much for your kind attention. Thank you.
And Atul, Dr. Mehta, I'd like to thank you very much. As we move on, before we get to the questions, I also want to thank the staff at ATS for putting this together. This has been a huge effort, and it's going to spread over quite a period of time, and we greatly appreciate it. So there are a number of questions here. I think I'm trying to just scroll through here and see. Will slides be available? No, I do not see questions yet for Dr. Mehta. Do you see any? Has anyone raised their hand?
It's almost 5 o'clock there.
Let's just give a couple of minutes here. Well, you are being thanked appropriately by numbers of participants here.
Thank you.
And if anyone has a question, could you perhaps type it in now before we actually wind up signing off here?
I will provide the slides to Liz, and she can forward it to anyone who is interested in looking at the slides.
Well, you've had quite a number of thank yous, and here is one question. Do you have recommendations for the first-year fellow on how to find tree and bud? I found it isn't easy until someone else points it out, and then it seems obvious. Can you help with that?
Yeah, you just have to, every patient you see, you must spend 10 minutes looking at the radiographic studies on these patients, and you have to correlate it with your physical examination. When you talk about tree in bud sign, as I already mentioned to you, that they are peripheral, 2 to 4 millimeter in size, and what you see is linear density with some nodularity around it. Once you start recognizing it once or twice, you cannot miss it on successive films. But always correlate it with the clinical findings. Usually these patients may even have squeaks on the examination, and that is a sign of bronchiolitis. So if you suspect that patient has got bronchiolitis from anything, viral bronchiolitis or if it is related to collagen vascular disease or rheumatoid arthritis, you listen to them and then go back and look at the CT scan of the chest and see if you can appreciate any of this tree in bud findings. So again, whenever you want to interpret any chest x-rays, having a good clinical information and physical examination is extremely helpful. And that would be my recommendation, that take a good history, examine the patient, and then go and look at the CT scan and try to correlate your finding with the CT findings. I hope that answers your question.
Perhaps I could just add something to that. And, I learned to read chest x-rays from John McClement at the chest service at Bellevue Hospital in New York. And we were taught a very rigorous approach to chest x-ray reading, a very systematic way of looking at things, looking at the least interesting areas first and then moving into the meat, as it were. So because we all have recognition issues with any kind of imaging study, do you have a pattern yourself for how you look at CTs?
Oh, yes. The thing is, now reading the CT scan of the chest is becoming more and more complex in the sense that, first I look at the scout film and make sure that there is no abnormality that is popping out that I can focus it onto. First, I would look at, this is just my style. I don't think there is any one particular method. I first go to the soft tissue window and look at the mediastinum. I start from the top and scroll down and try to identify all the stations which I'm interested in, 2, 4, 5, 7, and so on and so forth. So first I look at the soft tissue and then make sure there is no mediastinal abnormalities. Then I would go back and look at the parenchymal windows to make sure that I'm not missing any parenchymal abnormalities. This would also highlight some of the findings in the pleural surfaces and so on and so forth. I go from inside out. Lastly, I would look at the bones and the soft tissues, and that is how I look at my CT scan of the chest. Once I have done that, then nowadays I also, being interested in bronchoscopy, I also look at the coronal cuts of the CT scan of the chest, and many a times it would show you endobronchial lesions. It would show you congenital anomalies of the airways. So I am prepared I have a mental image what I'm going to see in the endobronchial tree. So this is how basically I look at the CT scan of the chest. Before I go into the bronch suite, I spend about 10 minutes looking at the CAT scan. And I'm walking in with a mental image of the endobronchial tree. People say that the procedures I do or the TBNA I do is a blind procedure. I would say no bronchoscopy is a blind procedure. Every bronchoscopist has a mental image of the endobronchial tree. So that is how basically I do it. Don't forget to look below the diaphragm. Often you will find the lesions in the liver or in the kidney. There could be kidney masses. If you're a bronchoscopist and you're doing a staging bronchoscopy, always look at the adrenal glands to make sure patient does not have adrenal masses or lesions that could be metastatic or adenomas, but we still need to look at it. And that is how I basically look at the CT scan of the chest.
Excellent. Well, thank you again, Dr. Mehta. Thanks to everyone who participated in this, ATS and the fellows. And again, I cannot express my thanks to the staff enough. And I think that concludes our session.
Thank you.
Thank you all.
5 o'clock.